My name is Laura Homan, a Master of Occupational Therapy student at Texas Women's University, and today I'm going to be demonstrating portions of a clinical examination of the upper extremities. We're going to begin the examination by looking at the shoulder complex. This part of the exam is best done in a standing position with both shoulders exposed. We're going to begin by looking at the shoulder complex. I'm going to start medially at the sternum to the sternoclavicular joint, then move laterally across the clavicle to the acromioclavicular joint. Below the acromioclavicular joint, you have the joint line of the glenohumeral joint. Laterally, we have the acromion, which is part of the scapula, the head of the humerus, as well as the humerus. And then posteriorly, we can follow the clavicle around to the spine of the scapula, and then the medial border of the scapula. We can also see the muscles of the rotator cuff, 3 of them. Here we have the supraspinatus, infraspinatus, and teres minor. The subscapularis we cannot see because it is on the anterior portion of the scapula. And up here we have the trapezius, which is overlaying the other muscles. It's important to look at the skin for any redness, swelling, or scars. You also want to look at the alignment of the shoulders, and also look posteriorly for any winging of the scapula, and you'll see that at the medial border of the scapula. Now we're going to move on to feeling the shoulder complex. You're going to start medially by palpating the sternum. And palpate the sternoclavicular joint and note any tenderness. Move laterally along the clavicle. The first 2/3 of the clavicle is convex, and the remaining 1/3 is concave. If you drop below the middle of the lateral portion of the clavicle, you will feel the coracoid process, which is typically tender. And move back up and palpate the acromioclavicular joint. From the acromioclavicular joint, you can move down and palpate the joint line of the glenohumeral joint. Laterally, you can palpate the acromion and feel the subacromial bursa. To best feel this, you can extend the arm backwards. To palpate the bicipital groove, you will move anteriorly to the acromion, bring your thumb down, and have your patient flex the elbow and externally rotate, and you should fall into the bicipital groove, which is typically a tender point for the patient. From there, you can continue down, palpate the humeral head, and move down the humerus. Posteriorly, you can palpate along the spine of the scapula, as well as the medial border of the scapula. Continue to palpate the muscles of the rotator cuff, the supraspinatus, infraspinatus, teres minor. You can also palpate the trapezius and the paraspinal muscles of the neck. It is important to also palpate the axilla. You can palpate medially, laterally, anteriorly behind the pectoralis muscles, and posteriorly for any lymph nodes. We are going to continue to moving the shoulder and looking for range of motion. It's important to remember that for range of motion of the shoulder, the motion is coming from 2 areas. The first 120 degrees of motion is coming from the glenohumeral joint, and the remaining 60 degrees is coming from the scapulothoracic joint. When we're doing formal active range of motion testing, we're looking for both extent and smoothness of the movement. First, have your patient abduct their hands above their head. Then drop the hands behind the head and push the elbows back. Bring the arms back up above the head and turn the palms out and slowly drop the arms down to the side. Beginning with the left arm, have your patient reach across the body and touch the opposite shoulder. Now do it with the opposite arm as well. From the lateral position, have your patient flex their arms above their head to 180 degrees. Then extend their arms down and behind their back. From the posterior position, reach with one arm at a time and touch as far up on the back as you can. Do this with each arm. This is testing internal rotation as well as adduction. Still from a posterior position, have your patient do a push-up on the wall. Here you are looking for winging of the scapula. From the anterior position, have your patient flex their elbows to 90 degrees and externally rotate their arms out to about 55 degrees. Then have your patient internally rotate their arms to about 45 degrees. If active range of motion is complete and smooth, it is not always necessary to include passive range of motion. But for the completion of this examination, we're going to include it. During passive range of motion, the examiner is looking for crepitus and feeling the infeel of the joints. For passive range of motion, hold down on the acromion, bring the patient's arm out and adduct. Then externally rotate and internally rotate the arm. Now we're going to move on to specialty tests of the shoulder, beginning with impingement testing. Impingement tests test for impingement, which is a common cause of shoulder pain. For the first test, hold the acromion down and abduct the arm to see if the patient has any pain. To perform the Neers test, hold down on the acromion, bring the arm up into full flexion and internal rotation. From there, you can move to the Hawkins maneuver. You want the shoulder and arm flexed to 90 degrees, adducted, and from here internally rotate. You want to see if they have any pain in this motion. We are now going to move on to formal testing of the muscles of the rotator cuff, beginning with the supraspinatus. The first test for the supraspinatus is resisted isometric abduction. To perform this test, have the patient with both of their arms, flex their elbows, and abduct their arms to about 15 degrees. The patient will resist you as you try to push their arms back into adduction. The empty can test is another test for the supraspinatus. For this test, have the patient hold a can, bring their arms out in front of them, and then turn the can over. Again, you're going to push down on the patient and have them resist you. To test the infraspinatus and teres minor, perform resisted isometric external rotation. So bring your patient's arm into flexion, 90 degrees, and have them externally rotate both of their arms out. The patient will resist you as you try to bring it in to internal rotation. There are two formal tests to test the subscapularis. The first is resisted isometric internal rotation. Have your patient bend their elbows to 90 degrees, internally rotate, and have them resist you as you try to bring them out to external rotation. The next test for the subscapularis is the scapular lift-off test. Have your patient bring their arm back to touch the small of their back, and then bring it out a few inches. Have them resist you as you try to push it back to the small of their back. Now we're going to demonstrate two tests of the bicep tendon. First, you need to find the biceps tendon, and you can do this by bringing your thumb down below the acromion, flexing the arm, and externally rotating. You should be in the bicipital groove, which is where the biceps tendon goes through. For the Yergason's test, with your thumb palpating in the bicipital groove, have your patient supinate their arm, and then have them resist you as you try to put them back into pronation while palpating the biceps tendon. For the speeds test, have your patient bring both arms out in front of them with their palms facing up, and you're going to push down on them to see if this elicits any pain in the biceps tendon region. To test the acromioclavicular joint, you can perform a scarfs test, where you bring the arm up over and across the opposite shoulder and stretch the joint. You can also bring the arm up and behind the head and stress the acromioclavicular joint that way. You will want to do both of these tests on either side of the shoulder. Next, we are going to test the glenohumeral joint for stability. When doing stability testing, you are testing for unidirectional instability versus multidirectional instability. To test the glenohumeral joint, you're going to reach below the acromion to the humeral head and test the glenohumeral joint posteriorly and anteriorly for instability. You can also flex the elbow and go down the humerus and pull on the humeral head to check for inferior instability. If there is inferior instability, this is called the sulcus sign. The last set of tests we will be demonstrating are neurovascular testing, both the myotome testing and dermatome testing. We'll begin with myotome testing from C5 to T1. C5 is the deltoids muscle. So you bring your arm up like this and have the patient resist you as you push down. To test C6, you want the biceps and elbow flexion and then wrist extension. C7 is triceps and wrist flexion. C8 is flexion at the MCP joint. And T1 is abduction of the fingers. Lastly, we will do dermatome testing. The C5 dermatome is on the lateral aspect of the arm. C6 begins at the tip of the thumb. C7, the tip of the long middle finger. C8, the tip of the little finger. And T1 is the medial aspect of the